Hello, this is Archana Arya. I'm an NP at Drexel Hill, working with Ready Clinic. I'm also doing my DNP, for which I had to do a project on health outcome. I decided to do it at Ready Clinic. Many people have worked very hard to make this possible. I would like to thank Larry, Tina, and Cyril to make this happen, and Dr. D for being a mentor and always being there to answer questions and boosting my confidence, and sometimes having more confidence in me than what I had in myself. Last but not the least, I would like to thank Kristen, my partner at Drexel Hill, who has been with on this project from me from the very beginning. She helped me decide on the project and has helped me look into different aspects of it, even though she has a very busy schedule with her little girl. Antibiotic resistance is a quickly growing, extremely dangerous problem. About 2 million people in US acquire a resistant bacterial infection. Almost 250,000 deaths occur each year caused by the resistant infection. About 20 million excess healthcare dollars are spent annually due to increasing antibiotic resistance. It is of paramount importance that we do something about this problem. Antibiotics resistance, one of the reasons that we have this is that we do not prescribe antibiotics correctly. Antibiotics are among the most commonly prescribed drugs used in human medicine. However, about 50% of the time, the antibiotics are not optimally prescribed. What does that mean? That either it is prescribed when it is not needed, or it is prescribed for a longer period, or an incorrect dosing. Another factor that we need to consider is that no new antibiotics are coming up. Thus, it is very important and it is of the responsibility of us, the clinicians, to our future generation to optimally prescribe antibiotics. Before I came to work for Ready Clinic, I worked at a pediatric office and saw many patients with ear pain. Middle ear infection is one of the most common diagnoses for children in the primary care, and acute otitis media is one of the leading cause for antibiotic prescription in children in primary care setting. Kids and adults definitely do need antibiotics if we diagnose acute otitis media, but diagnosis of acute otitis media can be quite challenging, particularly with children. I have been in the pediatric setting where the children are crying and parents are looking at me to decide whether I'm going to give them the antibiotics or not. The criteria supporting diagnosis of acute otitis media is middle ear effusion and acute inflammation, both together. To check for middle ear effusion, we check for abnormality in the color, opacity, decrease or absent mobility, or presence of bubble or air fluid interface of behind the tympanic membrane. For the inflammation, we check for ear pain, which may include tugging or rubbing of the ear in case of small children, marked redness of the tympanic membrane, and distinct fullness or bulging of the tympanic membrane. Thus, we can say a patient has acute otitis media if he has two or three signs of the middle ear effusion plus at least one sign of acute inflammation. One of the greatest tools to check the middle ear infusion is pneumatic otoscope. All guidelines, all guidelines, including the American Academy of Family Physicians, American Academy of Otolaryngology, Head and Neck Surgery, and American Academy of Pediatric Subcommittee suggest that we use pneumatic otoscope in the diagnosis of acute otitis media. But research shows that in spite of all these guidelines suggesting that we use PNO, clinicians are not using it in most primary care. When I did the literature review, I found that there were some barriers in the use of pneumatic otoscope and tympanometry. Even though pneumatic otoscope and tympanometry were both useful in the diagnosis of OME, the lack of training, the cost, and perceived lack of patient benefits were some of the barriers. Some residents, on the other hand, believed that it had value, but they didn't have the training and they didn't have the piano available. Another research showed that when they had interactive workshop and were given the pneumatic otoscope, this increased their confidence and use of pneumatic otoscope. We are also going to look in this study, are pianos being used at Ready Clinic? And if not, why not? And will this education and availability of this increase the use of piano and their confidence in diagnosis of AOM? Pneumatic otoscopy versus otoscopy. Otoscopy is what we are using at the clinics every day. It involves systematic inspection of the external ear canal and the tympanic membrane with the otoscope. What we are really checking in that case is the inflammation. We check for arrhythmia, we check for bulging of the tympanic membrane, we check for cloudiness, opacification, and loss of landmarks. What does pneumatic otoscopy do? It puts pressure, negative and positive, and checks for the mobility of the tympanic membrane. Thus, pneumatic otoscopy is the key to the diagnosis of middle ear effusion. Advantages of the pneumatic otoscopy are that it can be made very easily available. All we need to add is an insufflation bulb, and we can start doing the pneumatic otoscope. It is much cheaper compared to the tympanometer, and with appropriate training and experience, it becomes easy and simple to perform. Here is a picture of an otoscope which we use regularly at our clinics. We can also see a small hole where we will be adding the insufflation bulb. Here we can see some ear speculas. This picture has the insufflator bulb that we can see attached to the otoscope. Now we will discuss mechanism of pneumatic otoscopy. We have 4 different points, and we will go one by one on each of them. Normal tympanic membrane. So we are trying to see what will be the movement of the normal tympanic membrane when we apply pressure in the external auditory canal. When the pressure is increased in the external auditory canal, it moves medially 1 millimeters. On the other hand, if the pressure in the external auditory canal is decreased, it moves 1 millimeter laterally. Degree of tympanic membrane mobility. The degree of the tympanic mobility depends on many factors, one of which being presence of middle ear effusion. We also need to see the amount of effusion. It also depends on the amount of pressure that we apply in the external auditory canal. It depends on the tympanic membrane, whether it is thick, whether it's atrophic, it has tympanosclerosis, or a perforation. Reasons for an immobile tympanic membrane. Biggest reason is the presence of fluid in the middle ear. The fluid can be mucus, blood, pus, or CSF. There could be a perforation in the tympanic membrane. There could be adhesive otitis media, that is, that the tympanic membrane gets retracted and becomes sucked in the middle ear space and gets stuck. The reason for hypermobility of the tympanic membrane. This takes place when there is a negative pressure in the middle ear. When we reduce the pressure in the external auditory canal, there is a movement of the tympanic membrane, and this becomes hypermobile when the internal pressure of the middle ear is less. This also helps us to find out about the large central perforation. Next, we talk about the techniques of pneumatic otoscopy. One of the most important techniques that we need to follow in pneumatic otoscopy is to check for leaks. I'm going to show a video on how to do that. Here is the otoscope, and here is the ear specula. We will attach this ear specula on the otoscope We always pick the largest possible that is going to fit into the ear. Here is the insufflation bulb, which I will attach to the head of the otoscope. After this, we are going to check for the leaks in the system. The way we check for the leaks for the system is we occlude this area by putting our finger on top of the ear specula, and we squeeze this insufflation bulb, and we listen for the leaks. Where do we expect the leaks? We expect the leaks where the insufflation bulb touches the otoscope, and where the air specula touches the otoscope, and another place is where the lens touches the head of the otoscope. Another method of doing this is we occlude this area by putting our finger, and we press the insufflation bulb, and if we have not moved our finger from here and this occlusion is correct, and if we stop this squeezing, this insufflation bulb should not deflate. But in this particular case, we saw it did deflate. That means there is some leak present.